Welcome, everyone. This is the RUNX1 Research Program Medical Education Webinar Series. And today, the title of our webinar is Pulling the Molecular Thread Through Pediatric Thrombocytopenia, MDS, and AML. I'm Katrine Erickson. I'm the Executive Director of the RUNX1 Research Program. We are an advocacy and medical research funding nonprofit organization. For those of you who don't know who we are focused on realizing one goal, and that is to prevent blood cancers in our patients who have a rare genetic condition called RUNX1 familial platelet disorder. And we hope that the work that we're doing also will benefit others who are at high risk of blood cancers through other genetic predisposition syndromes. The purpose of this webinar is to educate on how and when to use genetic testing to achieve an accurate diagnosis in pediatric patients with either bleeding disorders, with MDS, or with AML, and really educate on why an accurate diagnosis is so important. I'm delighted to announce our incredible group of experts today. First, we will hear from Dr. Michele Lambert, who is Associate Professor of Pediatrics, the Director of the Platelet Disorder Program, and Medical Director of the Special Coagulation Lab at Children's Hospital of Philadelphia. She'll be followed by Dr. Tim Olson, Associate Professor of Pediatrics, a Medical Director of the Blood and Marrow Transplant Program, Director of the Research Comprehensive Bone Marrow Failure Center at Children's Hospital of Philadelphia. And then we'll end with Dr. Tanya Gruber, who is the Chambers Family Endowed Professor of Pediatric Cancer at Stanford School of Medicine and the Division Chief of Pediatric Hematology, Oncology, Stem Cell Transplantation, and Regenerative Medicine at Lucile Packard Children's Hospital. We will have some time, a very short period of time at the end for a Q&A. So please do submit your questions throughout as they arise during the presentation. Just use that Q&A icon button on your screen. And without further ado, I will turn it over to Dr. Michele Lambert.
Thanks, Katrine, and welcome everybody. I'm going to talk about the accurate diagnosis and management of pediatric thrombocytopenia, and I'm focusing a little bit on implications for pediatric ITP, and in part that's because that's the most common thrombocytopenia that we see, and we'll talk a little bit more about that as we go through this. These are my disclosures. So, thrombocytopenia in childhood, it's defined as a platelet count of less than 100,000. This is just taking hospital and outpatient encounters over the last 6 months at our institution for children aged 2 to 21 years, so children and adolescent, that presented with a diagnosis of thrombocytopenia in their problem list. And when we look at those children that have thrombocytopenia in their problem list, in most children, especially young children, this thrombocytopenia is transient and it's often post-viral. With increasing age, we see more and more children that have immune thrombocytopenia. So we see this ITP diagnosis becoming more and more prevalent as the children get older, but it still accounts only for about 40% of the thrombocytopenias that we see in the pediatric population. The rest of the children that have thrombocytopenia of other causes. And most of the time, this is secondary thrombocytopenia. So this is a low platelet count because they're getting a medication that causes a low platelet count, or they have a viral illness and this is transient, or they have a big spleen, or they have an inherited thrombocytopenia. So to talk briefly about immune thrombocytopenia comes in 2 flavors. There's a primary immune thrombocytopenia. This is when the immune thrombocytopenia is the only thing that we know about that's going on with the patient. And this is about 80% of those kids that we see with immune thrombocytopenia. And then there's secondary immune thrombocytopenia. And this is an immune response to the platelets that occurs because of some other process that's happening. Either that is some types of viral infections or bacterial infections, or because that child has an underlying immunodeficiency, or the person has an autoimmune disorder and the rest of their immune disorder hasn't yet manifested and they have immune thrombocytopenia, or they have a lymphoproliferative disorder. In adults, this is usually chronic lymphocytic leukemia, and in children, it's most commonly autoimmune lymphoproliferative disease or ALP syndrome. And then, of course, there are some medications that can cause an actual immune reaction against the platelets and cause the platelet count to drop. So secondary ITP is associated with an underlying immunodeficiency or autoimmune disorder, or because you have abnormal B or T cells in the immune system, or you have an underlying infection that causes dysregulated immune system, like dysregulated T cells in the case of mono or EBV or CMV infection, or an HIV infection. This type of ITP is more likely to be chronic, and you need to treat that underlying disorder. So it's important to understand what is causing the low platelet count in your patient, even if you think that patient has immune thrombocytopenia. And then it becomes important also to figure out if it's really ITP. So while ITP might be the most common reason that we see a low platelet count, particularly in some patient populations, it's not the only reason that we see a low platelet count. And it's really important to figure out what other things can give you a low platelet count in patients and understand what are the clues that might make you think that this is something else that's going on. So why not call it all ITP? Well, in the past, we used to call ITP idiopathic thrombocytopenic purpura. We don't call it that anymore because we actually know that ITP is an immune disorder. So it's now called immune thrombocytopenia. And because it's immune, we know that immune therapies can help that thrombocytopenia get better. But in cases of a low platelet count that aren't due to the immune system reacting abnormally to the platelets, that treatment is not going to be effective. So if you call somebody ITP and you give them immune therapies, but they don't really have ITP, you're not going to treat the reason that they have a low platelet count, and that's not going to work. And the other thrombocytopenias have other potential consequences and risks and implications potentially for family members or for other problems that may come up over time that are really important to understand and be able to counsel your families about. All right, so we make the diagnosis of thrombocytopenia in a patient, and we call it ITP pretty frequently. How often are we right when we call it ITP, or rather, how often are we wrong when we call it ITP? So looking at a recent study that looked at almost 4,000 pediatric and adolescent patients, that study actually showed that by 2 years from the diagnosis, so by 24 months, about 3% of those patients that were initially diagnosed as primary ITP, so ITP that is just ITP all by itself, actually had a revised diagnosis to either secondary ITP, ITP due to some other underlying immune problem, or non-immune thrombocytopenia, so some completely different reason for a low platelet count. And that's a study from 2021, so relatively recent actually, when we've already started thinking about not all low platelet counts are ITP. In 2011 and in 2017, Bryant looked at pediatric patients and Donnie Arnold looked at M.S.T.R patients, and they found 14% of children and 12% of adults had ultimately a different diagnosis. So potentially problematic treatments for ITP if you've got the wrong diagnosis. Let's look at the treatments for ITP and see why they might not be a good idea if you don't really have ITP. Corticosteroids have a lot of side effects. They can cause moon face or sort of big puffy cheeks. They can cause diabetes, high blood pressure, osteoporosis, avascular necrosis, particularly of the hips or changes in the spine. Some patients are referred for splenectomy, particularly if they have refractory or chronically low platelet counts that are not responding to steroids or other treatments. And if you don't have immune thrombocytopenia, a splenectomy is not going to help you and raise your platelet counts. And doing a splenectomy increases your risk of blood clots and infections. It's also potentially not the right answer if you have secondary ITP. So it's really important to really think carefully before making this recommendation. Using other immune suppressive medications can have potential toxicity to the kidneys or the liver and increased risk of infection. And then the TPO receptor agonists, which are very useful medications for thrombocytopenia, work by a non-immune mechanism. But it's really important before you embark on using these medications that you've carefully thought about whether or not your patient truly has ITP, because these medicines can treat some of the other causes of thrombocytopenia. And if you haven't considered that in your diagnosis, you may be falsely reassured that your patient has ITP when they respond to this medicine and really they have something else happening. So we've talked about the downsides of assuming that your low platelet count is ITP. It can result in prolonged treatment with the wrong treatment. It can also exclude the correct monitoring and follow-up. In other words, like doing a bone marrow for patients who might have a diagnosis that requires a bone marrow evaluation. And it excludes doing the right family testing and counseling. Because if you think this is ITP, that's a sporadic disease. That's not a familial disease. And you're not going to talk to your patient about the fact that this may be inherited from another family member. Okay, so what about your patient who has a low platelet count? Makes you think that they may have an inherited thrombocytopenia? Well, many of our pediatric patients will have a CBC when they're around 1 year of age because their pediatrician sent a full CBC to screen for iron deficiency and for lead toxicity. And so a lot of times we can get that 1-year-old CBC and see that that platelet count was normal previously. But if that platelet count has never been normal, you need to think about, do I have the right diagnosis? If the platelets themselves are very large or very small or highly variable in size, you need to think about, is this really ITP or is this some inherited platelet disorder? If your patient has other medical problems, particularly of the bones, the skin, of the heart or the kidney, or if they have early cataracts in their family, those are the sorts of things that make you think, maybe this is actually an inherited problem. And if there's a family history of multiple family members who had ITP, or multiple family members who have chronic ITP and a low platelet count, or family members with leukemia, you really need to think hard about whether or not this is truly ITP, because that makes you think about an inherited problem in the platelets. Other things that make you think about an inherited problem causing that thrombocytopenia is if your ITP doesn't respond to the typical ITP therapy. So you give corticosteroids or you give immune globulin and the platelet count doesn't go up. Or if your patient has unexpected or frequent infections or a family history of a lot of autoimmune disease, or actually ITP, that patient in the family actually responded to ITP therapies and went into remission after just a couple of months or something like that, then you need to think about whether or not maybe there's an immune deficiency in that family. All right, so when we think about the inherited thrombocytopenias, we've actually learned quite a bit about those in the last 20 years or so. And that's thanks to the advent of next generation sequencing. And we now know that there's over 50 genes that are associated with inherited thrombocytopenias. And remember, we call them inherited thrombocytopenias, but somebody in that family has to be the first person in the family to have the thrombocytopenia. And so about 30% of patients will have an inherited thrombocytopenia, but they're the first person in the family to have that variant. We know that there are many different mechanisms that can lead to the low platelet counts, different problems within the megakaryocyte. So you can have problems in the cytoskeleton, which tend to lead to more problems with platelets that give you large platelets, and potentially other problems that are associated with microtubule function, like problems with hearing in the MYH9 and DIAPH1 disorders, or problems with the kidneys. Tubulin and actinin mutations tend to really give you an isolated thrombocytopenia. And then Wiskott-Aldrich syndrome gives you small platelets, so does WIP1, ARC1B, and FYB. You can see problems with the duration in which platelets exist in the circulation by having problems with sialylation of platelets. You can have problems with platelet receptors that lead to a low platelet count because those platelets are not formed properly. Or you can have platelet problems with transcription factors, and so you just aren't really making enough platelets. And then there are other mechanisms by which we get low platelet counts when we have problems with the granules or problems with the mitochondria of the platelets, and that results in abnormal platelet lifespans. Many of these platelet disorders are associated with other clinical findings. So you get a little bit of a clue because there's something else about that patient, either in the family history or in the patient themselves, that gives you a clue that it's not just the platelets that are a problem. But there are a few of these disorders that are isolated just to the platelets themselves. So it's really important to understand, is it an underlying immunodeficiency? Is it an inherited platelet disorder? Most of the inherited platelet disorders are not going to respond to corticosteroids, immunoglobulins, immunosuppressive therapies, or splenectomy. They may respond to the TPO receptor agonists, though. And then again, the associated conditions, for example, for RUNX1, there's an ANKRD26 and ETV6 mutations. There's an associated risk of leukemia. And so it's important to counsel that family member who has that diagnosis and also talk to them about testing other potentially affected family members. It's really important for the family to understand their risk for development of leukemia. And then, of course, we also know that the possibility of passing these disorders to your children varies depending on exactly what your mutation is. For example, the RUNX1 related platelet disorder we know is autosomal dominant, meaning that you only need to have one family member that's affected, and Wiskott-Aldrich is X-linked, so it runs through the maternal side of the family. So what do you do if you suspect an inherited platelet disorder? Well, first, you need to get someone to think about that alternative diagnosis when you have a low platelet count. If you have a family history about low platelet counts or other disorders that might be inherited, it's important to get that doctor thinking about other disorders. It's also important as a clinician, if you are thinking about your patient with thrombocytopenia, to think about, is this an inherited platelet disorder, and consider additional testing. Genetic testing for the inherited thrombocytopenias or for inborn errors of immunity may be very helpful in this patient population. In addition, doing functional immune testing can help you get to the diagnosis because some of the platelet disorders are associated with immune dysfunction, and also viral testing may be helpful if you think that the thrombocytopenia is transient and associated with a viral infection. I ask my patients, if I am uncertain of the diagnosis myself, to get a second opinion. And this way I have somebody else look at that patient's information and just think about it with a fresh set of eyes. I think it's really good to make sure that you haven't gotten trapped by cognitive bias and really been stuck on a diagnosis that may not be the correct one. Not all genetic testing is created equal, and it's important that the clinician that's ordering the testing has some expertise in interpreting and in counseling patients about the test results. I like to have a genetic counselor with me to talk to the patients both before and after the test results. So talk about what testing we're going to send. It's important to be able to understand the types of results. Did you get a diagnostic result back? In other words, there is a pathologic or likely pathologic variant that you got back in a gene that matches the phenotype and therefore is probably the reason that you see a low platelet count. Did you get back a variant of uncertain significance that you can do further testing on in order to better understand whether or not that may actually be relevant? Or did you get back a non-diagnostic report? In other words, the cause of the thrombocytopenia was not identified on your genetic testing, but you're really sure this is an inherited thrombocytopenia because there's multiple family members that are affected. That's different than a negative test result where you know, for example, that there are several family members that have a RUNX1 mutation that is pathologic, and you send testing on another family member, and that test comes back without identifying that variant. That's a negative test result, and then that can be reassuring to the family. But when you're doing that initial screening test, a test that comes back without a variant in a family where you know you have an inherited platelet disorder is really non-diagnostic, meaning we don't know the answer yet because we haven't identified all of the genes yet that cause a low platelet count. And so what I tell those families is that they should come back and see us and continue to be monitored for their low platelet counts and for the development of other things that may help us to understand where to look further. But also we reanalyze their genetic testing every 2 to 3 years because we're really learning so much about this field that we're identifying at least a couple of genes every couple of months. And it's important for us to be able to reanalyze in order to be able to look for more answers for our families as we continue to learn more about these disorders. And with that, I'd like to thank you for your attention. I'd hand it over to Tim.
Thank you, Michelle. I'm going to talk about how to suspect and diagnose germline predisposition in patients with bone marrow failure and myelodysplastic syndromes occurring in pediatrics. The first point to make here is that bone marrow failure really exists on a spectrum with leukemia, and the in-between phase of this is myelodysplastic syndrome. And so rather than thinking of these entities as completely independent, it's very helpful to think of these as a continuum. And when you meet a new patient that is affected by one of these diagnoses, it's helpful to think where along the continuum these patients are. Recall that bone marrow failure is an intrinsic disorder of the bone marrow that is caused from disrupted hematopoietic stem and progenitor cell homeostasis. And it's that defect at the progenitor and stem cell level that is what leads to inadequate production of white cells, red cells, and platelets. There are two general causes of bone marrow failure syndromes: immune dysregulation or acquired autoimmunity leading to marrow failure, and germline genetic mutations that predestine a patient to develop bone marrow failure. And regardless of these etiologies, we know that bone marrow failure predisposes to the development of cancer. And so understanding these pathways from a germline genetic mutation through bone marrow failure towards MDS and hematologic malignancy is key to knowing how to best treat these patients. We have finally arrived at a molecular definition for myelodysplastic syndrome based on the most recent iteration of the World Health Organization guidelines for myelodysplastic syndrome. Back in 2008, when the original guidelines came out, the definitions of MDS were based nearly purely on pathologic criteria. And now we have come to a definition that recognizes that MDS is caused by a clonal hematopoietic stem cell neoplasm. And it's this clonal change in hematopoiesis that leads to the pathologic definitions that we have all come to know, that causes ineffective hematopoiesis that results in dysplasia, causes cytopenias as well. If you look at the 2022 definitions, we have some new terminology as well. Gone is the terminology of multilineage dysplasia, and low risk MDS is now defined as MDS with low blasts. Increased blasts, one has taken over for the definition of excess blasts. Increased blast 2 as well. So those are 5 to 9% for increased blast 1s and 10 to 19% for increased blast 2. And we still have a conundrum at the top end of the definition of myelodysplastic syndrome, where in Europe, 20% or greater in patients known to have MDS is considered MDS in transformation, whereas in the United States, 20% blast threshold meets criteria for AML. So back when I started in this field nearly a decade and a half ago now, what we talked about in terms of categories of MDS were those patients who had therapy-related MDS due to prior chemotherapy or radiation, patients who had known acquired or inherited bone marrow failure syndromes that drove the evolution to MDS. And then the rest of the cases were described as de novo MDS, like you would describe a patient with de novo acute lymphoblastic leukemia. Where we have gotten to through much research across the world is the fact that in pediatrics, we now feel that MDS is never really truly de novo. If you have developed MDS or AML arising out of MDS, we feel that in all likelihood, it is secondary to an inherited predisposition, whether that predisposition is specifically an MDS predisposition syndrome, whether it's associated with acquired bone marrow failure, or whether it was due to therapy-related causes, are the three categories that we have now. I will point out that even in the therapy-related MDS category, there is a suggestion that patients may have germline predisposition to developing the MDS. So why should we seek to understand what the genetic predisposition is for pediatric patients with bone marrow failure and MDS? Well, I think there are a few reasons for this. The first is because of the high likelihood of inherited predisposition in certain subsets of patients who have MDS and bone marrow failure. So for example, in a study out of Europe, they found that over 70% of adolescent and young adult patients with monosomy 7 MDS harbored a germline GATA2 mutation. And in a French cohort in studies led by Jean Soulier's group, what they were able to identify is a germline variant contributing to disease phenotype in over 2/3 of patients comprising a bone marrow failure, not otherwise specified, or MDS cohort. So it's very likely that you're going to find a germline predisposition in many of these patients. The second reason is because it's absolutely critical in stem cell transplant donor selection. So older adults with MDS, not all of those patients go to transplant, but we do feel that any young adult or certainly any pediatric patient who has organ function that allows it, these patients should seek curative therapy with stem cell transplant. And it's particularly important to rule out concurrent possession of the underlying mutation in potential related donors. And this is particularly important in patients who have variably penetrant disorders. And I'll give an example from our history here of a patient who presented us with monosomy 7 MDS at age 18. And we were fortunate to be able to identify a younger matched sibling donor for this patient. And we were excited to be able to move forward to transplant with this donor. But we did wait for the germline predisposition testing to come back. And lo and behold, we found a germline GATA2 mutation in the patient and also in the sibling. And in a prior era, had we moved forward with transplant using the matched sibling donor who had the GATA2 mutation, it's very likely that the transplant wouldn't have worked. So very important for related donor selection to identify the germline predisposition. And then finally, because many of these germline mutations have non-hematologic effects, and this is true not just for genes that are mutated in the classic bone marrow failure disorders like Fanconi anemia, and it's very important in your risk-benefit discussions when you're talking about curative therapies with families to make sure that they understand you are not going to fix the non-hematologic effects of the germline mutation with a bone marrow transplant, and in fact, you may actually make those issues worse. I will point out on the other side of the coin, there are select circumstances where you can diagnose patients with bone marrow failure where you can clearly identify that this is an acquired or immune-mediated bone marrow failure, and you may not need as extensive a testing for germline predisposition. And so our group actually looked at this to identify whether there were positive somatic mutations or somatic genetic alterations that could diagnose acquired aplastic anemia or immune-mediated aplastic anemia. and came up with two. So acquired loss of heterozygosity targeting the HLA region on chromosome 6p and PNH are clonal events that happen exclusively in patients with immune-mediated aplastic anemia. And so during the course of the workup for your patient, if you identify either of these two acquired genetic lesions, you can rest assured that this patient is very unlikely to have a germline genetic bone marrow failure condition, and you can move towards therapy for the aplastic anemia, perhaps before you wait for next generation sequencing or exome sequencing to come back. Germline predisposition testing is indicated for nearly all patients with bone marrow failure and MDS. So we conducted a study as part of the North American Pediatric Aplastic Anemia Consortium to look at current practices in the diagnosis and treatment of pediatric myelodysplastic syndromes. And what we identified in this study is that the vast majority of centers across North America have agreed on the types of germline predisposition screening that need to be done for these patients. So the vast majority of centers agree that chromosomal breakage testing and telomere length assessments should be performed for patients presenting with MDS to rule out Fanconi anemia and telomere biology disorders such as dyskeratosis congenita. Many centers also do enzymatic screening to rule out Shwachman-Diamond syndrome. The vast majority of centers will screen for germline mutations, including SBDS, which is associated with Shwachman-Diamond syndrome, genes associated with Fanconi anemia, dyskeratosis congenita, Diamond-Blackfan, and the listed genes that are associated with known MDS leukemia predisposition syndromes. Now, there are an expanding array every year of genes that are known to be associated with MDS and leukemia predisposition. And I show this slide to demonstrate the genes that should be included on panel testing if you are evaluating a patient with MDS or bone marrow failure for underlying germline predisposition. The genes that are shown in yellow are the highest prevalence genes. And so at a minimum, your next generation sequencing should include the genes that are listed in yellow. But if they can include all of the genes that are listed here and probably additional genes that have been discovered in the last couple of years that this slide may not include, the more genes, the better to try to look for underlying predisposition. The preferred tissue from which to assess for germline predisposition in patients with bone marrow failure and MDS are not hematopoietic cells or blood cells. They are skin fibroblasts. Skin biopsies can be done safely in these patients using the skin from the site of a bone marrow aspirate. If you try to look for germline variants in patients using blood samples, you end up with a couple of potential problems. First of all, if you identify a variant, you don't know if it's an acquired variant or a germline variant. And the second and even more problematic issue is you can have clonal reversion such that the germline variant might be eliminated by the hematologic clone, and you might actually miss the germline variant by testing from a blood sample. There are also limitations of buccal and saliva samples. The biggest problem with buccal samples is low DNA yield. Saliva samples contain high percentages of leukocytes, and so on some level, they are just like getting a blood sample. And I'll give you an example of where this came into our clinical practice. We had a patient that had come for evaluation who had been diagnosed with constitutional monosomy 7 mosaicism, and this was based on saliva and blood testing. So they had done saliva testing and they had identified the monosomy 7. When they came to our clinic, we did a skin biopsy, and not surprisingly, when we looked in skin fibroblasts, there was no monosomy 7 present, but what there was on our germline NGS testing was a heterozygous mutation in the gene SAMD9, which is associated with Mirage syndrome. Now, identifying the proper germline MDS predisposition syndrome is critical for preparing patients safely for stem cell transplant. All of these disorders have some manifestations outside of the hematologic system, as I mentioned earlier, and knowing what to screen for that can impact preparation and supportive care as you take a patient through transplant is critical. Right, so you need to identify Fanconi anemia and telomere diseases because their conditioning has to be completely distinct because of their DNA damage sensitivities. Other diseases such as RUNX1 FPD, you have to be aware of the underlying bleeding risk. GATA2 can be associated with lymphedema, can be associated with underlying infections that could be present before you go into transplant. So this is another reason why it's important to identify the underlying germline predisposition. Now, we are learning more and more about somatic evolution that arises out of different bone marrow failure and MDS predisposition conditions. And we're starting to be able to build maps along that continuum in the slide that I started with that can tell you how close to developing MDS a patient might be. So for Fanconi anemia, where most of the acquired genetic abnormalities are structural rearrangements, we are now able to define which lesions might be high-risk lesions, so things like monosomy 7, gain of 3q. For telomere disorders, we're starting to identify specific molecular lesions that are unique to these patients and that confer a risk of transformation to MDS. These include acquired mutations in genes such as U2AF1, ASXL1 as well. And unlike many of these other conditions, acquiring chromosome 7 deletion is relatively rare. The progression towards leukemia is probably most well mapped out in patients with severe congenital neutropenia, where we know that many of these malignant clones start initially with a CSF3R mutation. Acquiring a RUNX1 mutation puts these patients oftentimes into an MDS phase, and then acquiring additional structural rearrangements is what often pushes them into myeloid leukemia. And then in the case of Shwachman-Diamond syndrome, we now know that there are certain low-risk lesions, certain lesions that convey an uncertain prognosis, such as monoallelic P53 mutations, and then certain lesions which, if they've developed, confer a very high risk of developing MDS and AML, including monosomy 7 and biallelic P53 mutations. For the classic MDS predisposition disorders, we know that structural rearrangements are often the first hit in patients with GATA2 haploinsufficiency, and we know that there are certain somatic mutations that can occur as second clonal events within monosomy 7 or trisomy 8 that portend more aggressive disease and progression towards leukemia. In SAMD9, SAMD9L, we know that monosomy 7 always comes first, and there seem to be a progression of molecular events along the pathway to AML that involve ETV6 and CEPBP1 and others. In RUNX1 FPD, progression to MDS and AML can occur through loss of a second RUNX1 allele or through the acquisition of additional single gene mutations, and the most common of which are listed here. And then finally, with P53 and therapy-related MDS, we know that P53 can be the most common somatic mutation, but in many patients with therapy-related MDS, if germline testing is done from skin fibroblasts, the P53 can be defined as a germline lesion, and that might have predisposed not only to the original tumor, but also to the therapy-related MDS. So where we hope to get to in the future is, now that we know much more about the genes that are mutated that predispose to the development of MDS, we're really hoping that the next big development is the complete mapping of the progression of hematologic abnormalities within individual germline predisposition syndromes, such that we can use that map to develop an individualized molecular roadmap to predict outcome and perhaps personalize approaches to surveillance and therapy based on where individual patients might be along that map. So with that, I want to thank you for your attention, and I want to turn this webinar over to Tanya Gruber.
Thanks so much, Tim. I'm going to talk a little bit now about the genomics of pediatric AML and when you should consider germline testing for patients. The incidence of AML increases with age, and the disease in the pediatric setting is actually very rare, as you can see here. So it's a small number, relatively small number of cases across the US are diagnosed with AML less than 21 years of age per year. The treatment for pediatric AML is based on anthracyclines and cytarabine, with a subset of patients receiving stem cell transplant in first remission. And that chemotherapy is very myelosuppressive, leading to prolonged periods of pancytopenia, and that puts these patients at very high risk for infectious complications. The improvements in outcomes to date have really been the result of supportive care the incorporation of minimal residual disease monitoring, or MRD, and risk stratification. So I'm showing you on the right-hand side here event-free and overall survival curves for pediatric AML over successive treatment errors. So this is data coming from St. Jude Children's Research Hospital, and the studies in the 80s had actually a very low event-free and overall survival rate. And there was a big improvement when we transitioned to studies that were being reported in the 1990s. And one of the major reasons for that improvement was the use of antibiotics, not just in treating patients, but in trying to prevent infectious complications from occurring in the first place, and keeping these patients in the hospital given their high risk of infections. And then from the 1990s to the early 2000s, we were able to improve outcomes further by really optimizing risk stratification and looking at minimal residual disease monitoring and identifying patients that weren't responding well to treatment, and then slotting those patients to get transplanted in first remission. And if you look at the AML-02 study, which had a 71.5% overall survival, actually more recent studies haven't really improved much on that. That study was the first to use MRD as a mode of risk stratification. So we've really had a stagnant period. Some of the things that I think are coming up on the horizon is the incorporation of targeted molecules, but also I think improving our risk stratification can help improve outcomes further. And that's because whenever you are thinking about sending a patient to stem cell transplant, you have to recall that there's sort of a competing relapse versus toxicity. So you want to make sure you reserve transplant for those patients that really need it, and the patients that don't need it receiving chemotherapy. On the right, patients that are low and intermediate risk get chemotherapy treatment, and patients that are high risk go to transplant and first remission after several cycles of chemotherapy. And as I mentioned, MRD and genomics are the major factors that we take into account when we're risk stratifying. And the genomics have become increasingly sophisticated and has given us the opportunity to improve our risk stratification and really identifying those patients that need to go to stem cell transplant. Because there's a subset of patients that actually respond great to treatment that are MRD negative after 1 or 2 cycles, but go on to relapse almost without exception. And so identifying exactly who that's going to be is really important. This is an overview of a cohort of 436 pediatric patients with myeloid malignancies. And what you're looking at is every dot is an individual patient, and you're looking at the transcriptional state of that patient's leukemia cells. On the left, each case is colored based on the immunophenotyping that they had at diagnosis, and on the right, based on the major mutation that was identified in that leukemia cell. So what is the major driving event that caused the cancer itself? And so focusing in on the right, there's a high correlation between the mutational events and what the transcriptional state is. And I think that's actually very intuitive for most of us. And there are some groups of patients where it's very homogeneous. So for example, your core binding factor leukemias, which have fusions, either the AML1-EDO fusion, which is also RUNX1, RUNX1T1 rearrangement, or the CBF-beta MYH11 fusion. Those are patients that have a shared mutation and a shared transcriptional state. We do have a subset of patients that share a transcriptional state but have different types of mutations present, and you can see that on the bottom left-hand corner here, where you look at the gene expression that's quite similar, but actually the driving mutations can be quite different. And you can have driver mutations that occur in different transcriptional states. So if you look at FLT3 internal tandem duplication patients in yellow here, you can see they fall here either in the left-hand lower group or in the upper left-hand corner group. And that's because you can imagine, depending on what cell acquires these mutations and transforms into a malignancy, that can impact the transcriptional state of that cell. So the so-called cell of origin can impact your transcriptional state, but also how stem cell-like a given patient's leukemia cells are can also have an impact. So even within what looks like homogeneous groups of patients, so for example, KMT2A rearranged cases, which are here sort of in the center at the bottom of the plot, if you look at how stem cell-like a given patient's cells are, it's variable in this group of patients. So they share sort of a transcriptional state, they share an oncogenic driver, but there are differences in how immature that patient's leukemia cells are. And that can also be detected by gene expression or RNA sequencing. So when you take these different factors into account, how good are they at predicting outcomes? Certainly transcriptional identity, the mutation, the leukemia stemness as a single factor has a strong association with outcome, a statistical association, but you really get the best association with outcome if you combined all of these factors together, which is shown here in this Cox proportional hazard model. This is a pictorial of that concept where you have a cell of origin that acquires mutations, and that mutation can impact the transcriptional state of the cell, but also the cell of origin can impact that transcriptional identity. And then the cell of origin can also impact how stem-like that patient's leukemia cells are, which is a sign of treatment resistance. The more stem cell-like, the more immature a patient's leukemia cells are, the harder it is to cure. And so while we can't determine the cell of origin for every patient, we can measure the transcriptional state, the mutations that are present, how stem cell-like a patient's leukemia cells are, and all of that can be combined to risk stratify patients. Now, there are a subset of patients that actually have a mutation in their germline, so basically carrying a mutation in all of the cells of their body that predisposes them to developing a leukemia or another hematologic malignancy. And so what are those genes? This is a pictorial of the large childhood cancer cohort of over 1,000 pediatric patients. In this cohort, 588 patients had acute leukemia and 4% carried a germline mutation. Within those leukemia patients, there was 126 with AML, and only one had a germline mutation in a gene called SDHA. But I think this low frequency is actually a sampling effect, or I don't think it's powered high enough to show the true frequency. And that was supported by data from subsequent studies, which are actually smaller. A study of 72 pediatric de novo patients with a germline mutation rate with pathogenic known mutations of 19.4%, and in a study of pediatric therapy-related AML and MDS patients, a 15.5% germline mutation rate. So the true frequency in AML for pediatric patients with a germline mutation is probably somewhere between 10 and 20%. To the right, you're seeing what the most frequent mutations were in the childhood cancer cohort, and TP53 is by far the most frequent if you look at all pediatric cancer patients as a whole, and there's a significant number of those patients with the predisposition were leukemia patients. The RUNX1 gene is number 7 on the list, and interestingly, in this study was not restricted to leukemia patients. They actually identified a germline mutation in a patient with a CNS tumor. And so you always have to be careful when you make assumptions. If you find a mutation in a patient's leukemia cells, when should your suspicions be raised as to whether or not this is germline? And people have come up with panels of leukemia-associated predisposition genes, and this is showing you an example of one of those, and they're layering it over patients with solid tumors, showing you that some of the genes have been described in both types of malignancies, and some have been described just in patients with hematologic malignancies. But you have to take this with a grain of salt because, for example, the childhood cancer cohort, there was the AML patient with the SDHA mutation, which is typically associated with solid tumors, and is shown here on the solid tumor side. And so these panels are not perfect, but what I would like to point out is that if you do testing on a patient's leukemia cells to look at the mutations that are present, if you find a mutation in one of the genes associated with the hematologic malignancy, you really should be suspicious and get a good history to find out whether or not that patient should get germline testing. Because if that is a germline mutation, that is somebody you do want to send to transplant in first remission, because exposing them to chemotherapy but then not transplanting them, you're actually placing them at risk, higher risk, for getting another leukemia down the road. This is a study that tried to see if they could distinguish somatic from germline looking particularly at RUNX1 mutations. And I just want to show you on the left how difficult that can be. This is mutation data from 4 pediatric AML patients that presented de novo and enrolled on the AML-16 study at St. Jude Children's Research Hospital. And of these 4 patients that all had RUNX1 mutations in the leukemia cells, only one of them actually had a germline event. And we sent that patient to transplant first remission, even though otherwise they would have been stratified as intermediate risk. The data on the right is showing the study where they compared patients with AML that had germline mutations in RUNX1 to patients with AML, sporadic AML, that did not have germline RUNX1 mutations. And they looked at the other mutations present in the leukemia cell to see was there a difference in frequency between the two groups, meaning can you just look at the mutational profile and have a higher suspicion for one set of mutations over another. And there certainly were trends. So for example, if you look here at splicing factor mutations, that was something that occurred at a higher frequency in sporadic AML as compared to patients with germline RUNX1 mutations in the solid bar there. But certainly there were no absolutes in this study. And so I think really if you have a mutation in a gene that has been associated with familial inheritance or predisposition to heme malignancies in the tumor tissue, and you've detected it just in the tumor tissue, that is a patient where you really should send a predisposition panel testing done on their normal cells to distinguish whether or not it's germline, so you know whether or not to refer them for transplant. When you look across the US today, what kind of testing is being done, the majority of centers will do molecular testing on the tumor tissue for their newly diagnosed AML patients, and then refer patients for germline testing if they're suspicious. And historically, before all of this sequencing data came about, that was really based on a family history or potentially a history of having, for example, abnormal platelet counts and then suspecting potentially a RUNX1 mutation. But in this day and age, I think with all the sophisticated molecular testing that's done, it's going to raise our awareness, and we're going to start to see patients with leukemias that have mutations associated with predisposition genes, and that's going to lead to more germline testing in our patients. Ideally, you would do paired normal tissue and tumor tissue testing simultaneously, and that is being done in a small number of places, but is certainly not the standard of care at this point in time. And so when you think about sending your germline testing, there are a couple ways you can do this. There's single gene analysis, which is typically reserved for somebody that has a very strong suspicion for a particular gene. So if you know there's a family history of heme malignancies and somebody has received testing that shows a RUNX1 mutation, then that would be a patient where single gene testing would be fine. I think many of us have transitioned to targeted multi-gene panels. So there are several places where you can get a heme malignancy predisposition panel with genes similar to the ones I showed in the previous slide. And if that panel comes back negative, you may consider getting whole exome or even whole genome sequencing if your suspicion is strong. For example, the patient in the childhood cancer cohort, you wouldn't have picked up this SDHA mutation on one of the targeted panels because it's really not included in the heme malignancy predisposition panel in general. So I'll just finish up with a little bit of specifics in terms of RUNX1. Just remember that when you send a patient sample for Foundation 1 or other commercial tumor sequencing, and you're just sending the tumor tissue, the presence of RUNX1 mutation or another gene associated with predisposition can really be either of germline origin or somatic origin. So you really need to follow up and do germline testing. And so what kind of specimen can you use? This is actually very difficult for heme malignancies because blood is everywhere. And I think really the gold standard is to get a skin biopsy and actually grow out skin fibroblasts. And that of course takes time before you do the germline testing. Some places will send fingernails or saliva for patients that are in remission. Extreme caution should be used if you're going to send a blood sample of a patient that you think is in remission, because sometimes you'll get tumor contamination and you may get an erroneous result stating that there's a germline mutation when in fact that was actually residual leukemia that was present. So I'll finish there and pass it back to Katrina.
Great. Thank you so much, Dr. Gruber, and thank you also to Drs. Olson and Lambert for your wonderful presentations. Really, really appreciate you all taking the time to be here today. And we have about to be exact, 4 minutes for Q&A. And so please, if anyone has any questions, you're more than welcome to share your questions via the Q&A icon. I'll give folks a little bit of time to go ahead and do that. But in the meantime, one question I had for all three of you is, given that there is quite a high rate of inherited germline predispositions, high meaning, Dr. Gruber, in your presentation, you were just mentioning there were some studies that had as high as 19% had an underlying germline predisposition. How are your specialties maybe interacting within your institutions with each other? So whether it's working with a classical hematologist and then to really potentially coordinate care with across families when there's multiple affected families identified, and then taking it a step further, if you're caring for families over time, what does that transition look like when you go from pediatric to adult? And is there coordination there? And happy to have anyone jump in, or I can call on you.
Well, I'll just comment we definitely have patients that are spanning within our division all three subspecialties. So somebody who started out as a hematology patient came to me when they developed MDS and then eventually went to transplant. So we always joke she's the most popular patient in the division because all the specialists want to see her. So I think definitely there's a lot of coordination between us, and especially more and more we have a large bone marrow failure program. And so the hematologists that are following these patients initially are very frequently reaching out to both us and our stem cell transplant colleagues.
Great. Yeah, thank you.
I can talk about it from our side of things. You see part of the collaboration on here between Dr. Lambert and myself. I think if she has a patient that she's diagnosed, those conversations usually start that evening, and thinking through the families and what we might need to do and what we might need to consider. We're also fortunate at CHOP and Penn to have nicely established relationships with our adult hematologists at Penn, close research and clinical collaborators. And so if we have, adolescents that we have diagnosed and there are older affected family members, we work with our colleagues to make sure that they can be seen across the street here. So I realize it's not as simple at many other places, but we're a little spoiled here in that sense.
Yeah. Well, thank you for that.
Super lucky, because I'll just send an email and I'll say, oh, and by the way, mom and dad need to be tested too, or mom's side of the family has leukemia in the family, or mom has thrombocytopenia and the parents need to, that side of the family needs to be tested too, or there are 3 siblings and they need testing. We actually are fortunate enough too to have a genetic counselor that's part of our platelet disorder program, and helps with the bone marrow failure patients as well. And so, 2 genetic counselors, we get half of each of them. So, and they're phenomenal and help us to, track down results of testing from other places and get authorizations for testing and everything. So it's been.
That's great. And it's a huge value add. And I think I would just say to the people who are on the call who maybe don't have access to that, if it makes sense, it can in the long term make sense to refer families to larger institutions because of that coordination. So we actually have quite a few questions coming through here, and I'm gonna, if you're all okay staying on for a few extra minutes, let's try to get through some of these. One question here, is it needed to repeat molecular genetic tests and NGS in a relapsed AML patient?
Yeah, if we have a patient referred to us and they send us a somatic report and I'm suspicious and they haven't received germline testing, then I certainly would do that in the relapse setting. If they have been followed at our institution and there's really, we've already addressed it in the first time around. I wouldn't resend testing in that instance.
Great, thank you.
Can I just comment on that too? It depends on when and how a little bit when you're talking about germline predisposition. And, you know, I don't think that this would happen for most patients with RUNX1, but occasionally patients with germline predisposition are treated with chemotherapy only. And if that were to happen, and you were to say have a relapse 2 to 3 years later, that may not actually be a relapse. That might be a new leukemic clone. So I think that's a little bit of a different scenario where one might want to think about repeating the genetic testing.
And an example of that kind of patient would be like a Shwachman-Diamond syndrome or GATA2, or those the groups that would not go to
so those should all go to transplant, but there
Okay.
are predispositions such as CEBPA,
CEBPA.
where it's not necessarily the case that you're going to go to transplant with, you know, if you achieve a complete remission early in therapy. But if there is a second malignancy down the line, I wouldn't necessarily assume that it's going to be a relapse of the original clone. Makes
sense.
Right, but that would be a secondary AML and not a de novo. So I think you're talking about somatic mutations, correct?
In CEBPA, I think it's been shown that you can have 2 entirely different clones cause leukemia, and in a sense, you could think about it as secondary, but it may or may not actually be. It all depends on how you parse the terms, I think, a little bit.
Yeah. And how sensitive your initial testing is and whether the clone was there initially. Sure. We have another question here. We usually send blood to services doing gene panels. Do most of these commercial services accept skin biopsy? And any practical guidance as a pediatric hematologist doc on how to get skin biopsy easily, as often I may not be doing a bone marrow biopsy? What do you advise? Or should I just relearn how to do a skin biopsy? Pediatric, must be not a classical hematologist, I guess is what is the question.
I mean, Mac just learned to do the skin biopsy again. It's so easy.
You know the individual. Okay.
But
you know, I think the real question is, if you have somebody with RUNX1 FPD, you know, there may come a day where cell-free DNA testing and other things are going to be able to do the same level of surveillance that a bone marrow biopsy can do. I'm not sure that we're there yet. And so the real question is whether patients who have a known predisposition should be getting surveillance with bone marrows. It may not need to be every year, depending on what the underlying predisposition syndrome is, but the likelihood of needing to do one at some point over the span of a couple of years is pretty high, and that's the easiest way to couple a skin biopsy.
Thank you, Dr. Olson. This is an important question because I think it extends beyond RUNX1, but the question is, do all patients with RUNX1 positive, who are positive for a RUNX1 mutation at the time of an AML diagnosis, should they or do they undergo germline testing? And is it different for pediatrics versus adults? And then I can answer the last question for RUNX1 specifically. Is there an online repository to check if a mutation is pathogenic or not? For RUNX1, we have a RUNX1 database that has, you know, a whole listing of all germline mutations that have been reported, but you can also find this information on ClinVar as well for other genes. But maybe Dr. Gruber, you can answer this since it's pointing out AML diagnosis.
Yeah, I mean, we get a very thorough family history. And certainly you can't even really depend on the variant allele frequency because, for example, if your tumor didn't acquire the second hit, you may have a 50% VAF of a mutation that's associated with germline, and it's actually the germline. So I think your suspicions should definitely be raised. And I think it's really critical to understand whether or not this is someone who should get chemo versus stem cell. And I would err on the side of caution and send testing.
Not to mention, it might be important. I mean, you know, if you're an adult, you might have children already. It may become important for talking to the rest of the family for their risk. And, you know, how are you going to counsel them? As the pediatrician, you know, who has seen the children of some of those family members later, after a couple generations have had leukemia, and nobody did the testing prior because we didn't think of it before, but like now, I think it's worth considering. Why would you not do the germline testing rather than why do the germline testing, even in adults with the RUNX1 in their leukemia?
Yeah, I can tell you for me, the only way I don't do germline testing in a patient or germline testing of for RUNX1 mutation in a patient who we found the RUNX1 mutation in their marrow is if they have another genetic predisposition syndrome that we've already identified. Otherwise, we do it.
Thank you. Thank you, everyone. I'm going to ask one more question and then we can close. And that is specifically around the age range. What age range in patients with myeloid malignancies should we be testing for germline predispositions? I know for a long time people have said, oh, anyone under the age of 30, and but what are your thoughts on this? I know you're all pediatric physicians, but should there be an age range?
I hesitate to give a limit because sometimes when we identify a patient, we'll go back and the family will get testing, and you find adults who had no idea that they carried a cancer predisposition mutation. And so I hesitate to put a limit on the age.
Yeah. Thank you, Dr. Gruber. Yeah, I mean, I agree. And I know from at least the adult world, you hear now about how common DDX41 is, for example. And these are individuals who are getting cancers much later, like in their 70s and even 80s. So, well, thank you. I really appreciate all three of you again for your wonderful presentations. And thank you to the audience for joining and learning with us and for your questions. And I wish you a great rest of your day. Take care, everyone.